Thank you. Thank you. Thank you so much. Yes, I was born and raised down on the bayou, but I lost my accent somewhere along the way. But if I ever get back home, or when I get back home, it comes out pretty much fairly easily. And so you'll see me pick up a few of these cue cards every now and then. It's just to keep me on track. And what I'll like to talk about today, or I'll spend a little bit of time on the adverse effects that weight has on our bodies, although we do know that, and there's going to be speakers elsewhere who go a lot deeper into the subject. What I want to spend a lot more time on is, why is it that we gain a lot of weight as we get older? Why do we gain weight in a certain region as we get older? And what are the best ways to correct that and change that course and help us lose some weight? So I will. Oh, and by the way, yes, one of the things that she spoke of, Dr. Rodning, is one of my surgical mentors, and I started out as a general surgeon. And the general surgeon does all the abdominal type surgery, and then I specialize in bariatric surgery, most of which, and if you see a lot of the guys that came out of my residency program, a lot of us chose to do weight loss surgery, and that's because he had a profound effect, almost like a fatherly figure on us. And he loved weight loss. He knew how to communicate with people who were overweight, and he really kind of touched a lot of the surgeons and served as that father figure for us, which is why a lot of us went into weight loss surgery. And that's why I did it for so many years. I did it for 25 years, and then I hung up my scalpel about 2 years ago, and I started doing medical weight loss. I work with 2 bariatric surgeons now. They do the surgery, and I do the medical side, which I really do appreciate and really like. We're supposed to put no financial disclosures. I'm not being paid to be here or to discuss anything that any medications or anything like that, although I keep that very vanilla. So the first thing I want to talk about is sleep and how sleep affects. So it's very important to get good sleep, but sleep is adversely affected by our weight. I could give a personal story because I know even without a scale when I pass or exceed 190 pounds, because I'll wake up with bruises on the right side of my arm. And that's because I start snoring at above 190, and my wife elbows me during the night to get me to roll over on my side so that I stop snoring and she can get a better night's sleep. So even without a scale, I know when my weight creeps up above 190 pounds. So it's very common in men. Sleep apnea is very common in men. It increases as we get older and certainly increases as we gain weight. And let me see. And that's because we go through several changes as we get older. And I like to put this deer slide up here because if there are any deer hunters, if you've ever been deer hunting, you have to look at certain cues to see how old a deer is. So a younger deer, even though it can have a really big rack, will have a very slim neck and a very slim body. That's how we were when we were younger. As a deer gets older, neck gets bigger, and they get bigger around the middle. Same thing happens in people. So bigger necks, more, things to constrict on the airway, and we get a lot of sleep apnea. So even with a modest gain in weight, we are very predisposed to a lot of sleep apnea. And so what you need to do is get better sleep. And it's a vicious cycle. So the more weight you gain, the less sleep you get, and it's much harder to lose weight with the less sleep you get. So in order to break that cycle is to start by losing the weight. Losing the weight, you'll get better sleep, and then eventually that will be one less impediment for you to lose or continue to lose weight. So luckily, and when you look at it, one of the first places we do lose weight whenever we start to lose weight is in the face. So a lot of people will come to you if you lose 20 pounds and say, wow, I can see it in your face, you've lost weight. And that's important because that will have an impact on your ability to sleep. You'll snore a little bit less. You'll get better sleep at night. Roughly 7 to 8 hours of sleep is the ideal amount of sleep you want to get. And then it certainly affects your sex life. So we know that there are very few things that are advantageous in your sex life about gaining weight. So there's a whole lot of negatives that come about, and I think there's going to be a urologist speaking a little bit later, and I think they'll go much further into this than I would like to go into it. But just suffice to say that gaining weight affects you in multiple different ways, one of which is your testosterone to estrogen balance. So fat, we know now, produces a lot of hormones, and some of those hormones are estrogens, which upsets the balance of testosterone to estrogen ratio in our bodies. It promotes infertility, erectile dysfunction, and certainly leads to mood changes. Luckily for us, men, we're very simple creatures. So when I look at my practice, probably 80% of my patients are female, only 20%. If you look at female hormones, very complicated, multiple hormones doing multiple different things in the body. Men, I think most women would say that, we're simple creatures. So we have one hormone, it goes up, we have a better libido, we have better moods, more energy, and our mechanics go up. If our testosterone levels go down, all those things go down. So when we lose weight, we'll get more testosterone, more exercise. So certainly exercise is a very important component. All those endorphins that are produced during the exercise or the act of exercise will help as well. So that's just a little bit about how gaining weight adversely affects your sex life. And then, I don't know, I think it might even be going on right now. We have a cardiologist, Dr. Lamont, who's supposed to talk about its effect on your heart and your cardiovascular system. And it does that by way of inflammation. So if you look at increasing your weight, it's a very inflammatory condition. So when our body is inflamed, so the more weight we carry, the more inflammatory chemicals float around our bodies, and it leads to a lot of different things. One is increased heart disease, certainly increases our risk for cancer, and it increases our risk for diabetes. And that's kind of like another cycle, a vicious cycle, because the more weight we gain, the more we become at risk for diabetes, and the worse our sugar components happen or come about, the more weight we're apt to gain. So it's very important to decrease the amount of inflammation. Now the way we do that, certainly, again, exercise. Certain types of diets, too, are known to promote decrease in the body's inflammation. And it's usually involving much more vegetables. So if you look at the type of diet that we tend to eat, way too high on the processed foods and starches, way too low on the amount of vegetables, which have inflammatory or anti-inflammatory components to it. And I can tell you, operating on people for many, many years, that the type of weight we gain later in our life is a different kind of fat. So any doctor who operates in the abdomen will tell you that there are different kinds of fat. So when you go in there and you look, people that tend to put their weight more peripherally, they tend to have what we call a gentle fat. It's softer, it's easy to work with, it doesn't really get in the way when we're operating. We used to coin the term whenever we'd get, and usually it's men, with the really hard bellies. And you'd go in there and you look at it and we'd call it angry fat because it was hard. It was hard to work with. And when you try to cauterize it, it would like little plumes of vapor and steam. So it made it very, very difficult to work with. And you knew, the bad side, yeah, we knew we were in for a little bit more of a struggle with this particular operation. But the good news was we would have a dramatic impact on that patient's health afterwards. We knew that decrease in that weight and that decrease in that inflammation would make a big old difference. But then again, why do we struggle as we get older? And then I'll touch upon what can we do. So I'll go back to when I was in med school and what we thought at the time was the triggers for gaining weight. Most of the time, say 70s and 80s, we thought it was all up in the head. We just thought some people just couldn't control their appetite, couldn't control their cravings. So when they went about to make pharmaceuticals to work on that, it was all geared towards the head. So let's find something that will attach to those parts of the brain that we know are the appetite control centers, the craving control centers. So for many, many, many years, that's where the science was, that's where the pharmaceuticals were. And it was really only half the story. Because later, starting in about the 90s, is when we started to discover some of these chemicals. Actually, a lot of these were kind of discovered here at Pennington, where we started to learn that the gut actually communicated with the brain. And there were certain things that the gut did, or hormones that the gut produced, that actually caused our appetite to go up. Some of those caused our appetite to go down. That's where the newer studies started to come about. And when we look now, most of the newer weight loss medications are coming about from the gut section and how it interacts with the brain as well as the gut. But this is what I really want to spend a lot of time, because insulin resistance. There's a few commercials you'll hear on TV every now and then where it's a weight loss product and they'll talk about insulin resistance. And it's a mixed opinion about it in the medical community. You may find doctors that will tell you, I don't believe in this insulin resistance thing. I'm not sure exactly what it is, but it's there. It really is something. Now, it's not a disease, so it's not anything that's going to adversely affect you unless you start looking at how it plays a role in you gaining weight. So it plays a very important role in how people gain weight. And we're not exactly even sure what's causing it, but certainly insulin resistance is something that's having an impact. So in order to kind of explain it to you in the way I explain it to patients is I'm going to take you through a normal cycle, what usually happens when we eat. And I'm going to use a food that is not my favorite food. It's a potato. Because when you really look at a potato, it's an unsweet big ball of sugar is what it is, and that's what it is to your body. So when you eat a potato, if you're an efficient person, and most of us were like that when we were younger, that goes into our stomach, and that starts to send signals to our pancreas and other organs in our body, and it says, hey, be prepared to make some insulin. So finally your body absorbs it, it comes in as sugar, floats around your bloodstream. It's almost like a lot of people here work in the chemical industry. It's like you're watching a valve. It's letting you know how much pressure is in the system. So that's your sugar. So it's a certain level of sugar starts to go up, and your pancreas opens up the valve and starts making insulin. It just wants to make a little bit so that when the sugar starts flowing through your system, in an efficient system, your muscles are triggered. They open up the door, and it allows all the sugar to go in. Blood sugar goes down. They turn the valve and the body stops making insulin. Ideally, it's just a little bit of insulin that's made, and that's a perfect system. So most of your calories go to your muscles. Your muscles know how to do one thing with a calorie, and it burns it. But then there comes insulin resistance. And we started to see more and more of this somewhere around the 70s, and that's right around the time where we started having more and more processed foods. So there's something in processed foods that started to trigger our genetic tendencies toward insulin resistance. So what happens with insulin resistance, your muscle cells become resistant to the insulin that the body makes. So the body is a very accommodating machine. So what it does, it just accommodates. It makes more insulin. And that's an all right thing. So I look at insulin as a key that opens up a door, and the door is in your muscle cells. So your body's making a whole bunch of keys. It goes to the locks. And all of a sudden with insulin resistance, these are rusty locks and it won't open. So what your body does, we'll just have to make more keys. So it just keeps making more and more keys. Finally, it overwhelms the system and it starts opening up doors. The problem comes with insulin resistance. At low levels of insulin, only your muscles get stimulated. At high levels, your liver and your fat cells get stimulated. So a greater portion of your calories are start to divert towards your liver, causes fatty liver, high cholesterol, and certainly goes to your fat cells, and it causes weight gain. So one of the things that I look at and I try to tell people is if I detect that you have some element of insulin resistance, yes, we can do your diet. We could make sure you start exercising, and we may even provide you medication to decrease your appetite. But if your system's still not efficient, you won't be as successful. So we need to add what I call a metabolic medication, a medication that will improve the system, kind of fight the insulin resistance along with it. So what to do? Eat right and exercise. I'll hit exercise first. So people often ask me, what's the best exercise to lose weight? The one that you'll actually do is the correct answer. I don't care really what it is, but whatever you like is usually going to be something that you will do. So it's better to do something. Weight loss is all about consistency, not about intensity, so you won't sweat off your calories with a high impact, high intensity type of exercise. Your body responds more to consistency. So when you look at it, I tell people to start small. So if you're a non-exerciser, if you haven't started exercising, tuck away 5 minutes. Get yourself to build that habit first. So if you go for a 5-minute walk, much harder to talk yourself out of a 5-minute walk than it is to talk yourself out of a 30 or 45-minute walk. So start small, make it consistent, something that you will do, something that's pleasurable. Get a buddy to do it with you. So if you have people with you, you're much more likely as a social aspect to keep doing that exercise as well. Now for eating, I'm a big fan of the Mediterranean diet. And that's for one key reason. It's a long-term doable diet. So if you look at a whole bunch of different diets, let's take keto, for example. Keto is a great weight loss diet. But very few people, certainly very few people in the state of Louisiana can stick to a keto diet. And that's because our environment, we're around people. Maybe in California there are certain pockets where carbs are public enemy number one. You can function because everybody else around you is eating the same way. In Louisiana, that's not going to be the case. So keto diet, although it may be good if you could want to do it for a little while, but I always tend to push people more towards a Mediterranean style of diet. And I tell people, another name for a Mediterranean diet is good eating, is what we all should be eating. It's higher in vegetables, your meats are better, so it promotes more fish. I kind of modify it and say fish and chicken. You can do steaks, pork, occasionally, but not all the time. Something that's more rare. So I'm a big fan of the Mediterranean diet for one main reason is that it's something that people can eat that way for the rest of their lives. And that's going to be important because one of the hardest things I find with men is we're programmed to eat like we did when we were in our 20s. That's for me the biggest fight. I'm a man, I'm big. I need this amount of food in order to function. Well, like Mr. Morgan said, when's the last time you looked in the mirror? It's obviously not going to work out that way for you. So you need to adjust. We all have to adjust. Our bodies change as we get older, and the amount of calories we need on a day-to-day basis will eventually start to go down. So that's a key component there. And then these are the medical treatments that we have for weight loss. The thing I didn't put on this, and I want to kind of talk about it first, it would be surgery. It's not anything that I do any longer, but I still think it serves a very good purpose for some individuals. It's a very good thing. But one of the things, medications, surgery, it doesn't matter what it is. If you have the ability to gain over 30 pounds and be at least 30 pounds overweight, your body's telling you something. You have a genetic predisposition for gaining weight fairly easily. Just like a person who has high blood pressure has a genetic predisposition to having high blood pressure, same thing with weight. And so now one of the things that they preach when you become an obesity medicine specialist is obesity is a disease. You're living with this disease, and it has to be something that you deal with the rest of your life. So just like blood pressure, doctor puts you on blood pressure medication, your blood pressure goes to normal. He doesn't take away your blood pressure medications and say it's fixed. Same thing with weight. Once you get to that good weight, it's not fixed. You have to continue always, whether that be exercise, diet, if you can do it with those. And I like to term them, those are the first two medications we put people on, diet and exercise. But we may also choose some of these other medications. And if we have to, we need to look at these as long-term medications. Certainly the more metabolic medications are meant to be used that way, meant to be used more in the long term, because that's the way we have to look at our predisposition to weight gain. So right now, to me, I think I did it at the perfect time. I became a medical weight loss doctor right when they started rolling out a lot of these newer medications. It was a very exciting time. So if you look at it, we have our traditional medications. Those are the brain medications. So that's the phentermines, the Adipex, the diet clinic type medications. And they're very good medications, and you have to use them judiciously and in the right combinations, and combinations with some of these other metabolic medications. But they do help reduce your appetite, and they do help reduce your cravings. In there that I don't have in there is my old standby metabolic medication. That's metformin. So anybody with insulin resistance, I like to use metformin as a long-term medication. It's a very good medication. It's being studied now, especially here, for Alzheimer's as well. So it's got a lot of benefits to it. It's a little bit of an uphill battle for me to convince patients to use that medication long-term. They kind of refer to it as a diabetes medication, but the indications for it is much broader than that. We use it for women with polycystic ovaries. And like I said, they're studying it now for Alzheimer's, so I think it's got a lot of benefits. And then these are the newer drugs, these newer metabolic medications, GLP-1 agonists. These are all what people kind of referring to right now as the shots. The doctor prescribed this shot for me, and it's caused me to lose weight. And it really is fairly impressive. It giving, in some patients, they'll lose as much as the surgery patients lose. But for the most part, it fills in that gap between diet and exercise and the older medications. And they'll get a good, I'd say, 50, 60-pound weight loss. And if we're able to keep them on it for a period of time afterwards, letting their body adjust to the new weight, they're very good medications to use. How much time do I have? You're fine. All right. Okay. So if you look at it, so the top one would be more like semaglutide or Ozempic and Wegovy. So when it comes in the version for diabetes, if I have a patient who's struggling with their weight and they have diabetes, I prescribe Ozempic. If they don't have diabetes, I prescribe Wegovy, which is the same drug, just go by two different trade names, but it's semaglutide. The next one is termed tirzepatide is the trade name for it, or the generic name for it, and the brand name is Mounjaro. Right now it's just a diabetes medication, but it's probably going to get approved for weight loss within the next year for sure. And then this last one we call the triple agonist is, so if you look at the first one, it's got one little, I guess, chemical compound that stimulates the body. The second one has two of them, which improve the weight loss profile of it. And that last one's going to have three, and that one's in studies right now. And that people are very excited about the possibility of what these medications can do for people. That one is called retatrutide. It hadn't had the drug company name applied to it just yet. I'm sure they're going to have focus groups and come up with a little catchy name for it. But all the doctors that practice obesity medicine are really excited about all these medications because they work very well, they're well tolerated, and it's a shot, but it's only once a week. and the needles that come on the little pins for it are very, very tiny. So, and most of them come with little pins that you can't even see the needle. In case anybody has a needle phobia, don't even have to worry about that. So, just in summary, in terms of diet, Mediterranean diet is basically eat more vegetables. We just don't eat enough vegetables. We eat way too much starch. I know we grow rice here, and it's good to support rice farmers, but we don't have to eat a lot of it, and we don't have to eat it every day. You want to choose your meats correctly. And even when you lose your weight, you have to transition over towards a maintenance type diet. And I like to tell people during the week, eat good. And if you want to kind of let loose a little bit on the weekend, go ahead, maybe choose 1 or 2 meals, and then come Monday, get back to normal again. And you also have to have a plan. I don't know, missed that on my little notes. You have to have a plan. So just don't go into it and think, all right, here I'm just going to do it. Try to set up a plan. Have a plan for your exercise program. Have a plan for your eating plan. We're big on tailgating here. I've never, ever, ever heard of a tailgater saying the night before, say Friday night, this is what I'm going to have on the tailgate on Saturday. You've done weeks of planning going into that tailgating. Same thing, that same amount of energy you want to apply towards your healthy eating plan as well. And then your exercise, maintain your muscle. Because insulin resistance, which is one of the things that are, especially now, promoting a lot of advanced age weight gain, you need to protect your muscles because it's a disease of the muscles. It starts in the muscles. Our muscles get resistant. And a lot of it's because we're sedentary. So one of the ways to counteract it as well is to do resistance training, do exercise, keep up with it, and keep our muscles healthy. And then ask your physicians about weight loss medications. There are very good weight loss medications. If they feel comfortable prescribing it, I would say go ahead and do it. If they don't feel comfortable prescribing it, there are more and more of us every year becoming weight loss specialists or board certified in obesity medicine. And you can find one of us, and we'll be happy to help you out with some of these medications because it really does a good job. And I think that's it. Yep, oops.